Good afternoon, friends and colleagues. I think I know most of you, but for those of you who I don't know, my name's Fiona Lecky. I'm an interloper here. I'm not a neurosurgeon. I'm not an intensivist. I'm an emergency physician, and I work in Sheffield and Manchester in the UK. And I'm also the research director of the Trauma Audit and Research Network, which is the largest European trauma registry. So thank you for the opportunity to present the preliminary findings of the registry work package. So the registry has been contributed to by all the CENTER-TBI recruiting centres, but the main investigating centres are colleagues in Antwerp, Rotterdam, Cologne and Monash, and also my own group in Sheffield. And I'd like to thank Olubukola Otisile, my research assistant in Sheffield, who's prepared most of the analysis that I'm going to show to you today. As Andrew's already said, the purpose of the registry is around the validation of the core study externally and internally. And the inclusion criteria for the registry are the same as the core, with two important exceptions. Within the registry, we're including patients who are so severely injured with traumatic brain injury that they die in the emergency room before they get a CT scan. And we're also including patients with pre-existing cognitive impairment. What we're going to do with the registry data is two things. We're going to enlighten ourselves about TBI epidemiology across Europe, which Andrew has already explained is not well understood, by looking across the stratum in the registry and comparing the ICU admission and ER strata. And then when we compare the strata within the registry to that in the core, we'll get some insights as to the internal validation of the core data. Just to highlight some of the differences in the data collection between the core and the registry. So on average, I would think it takes a collaborator in a CENTER-TBI centre about 40 minutes to collect and enter the data into the CENTER-TBI register. And this is because all the data collection is done from the patient's clinical record. There is no direct patient contact, there is no laboratory or imaging data collected. So all the data is clinical data that's already in the record, and it's extracted and entered into the CENTER-TBI registry. There's also no patient consent, but we have IRB approval in all the different centres. So this means there are far more patients in the registry than there are in the core. This slide shows you the numbers of patients in the registry and the core. We extracted from the core at the end of October and the registry from the middle of September to present this analysis to you. And this slide shows the actual numbers in the different stratum in the core and the registry. This slide highlights some of the differential recruitment to the different strata within the core and the registry. So you can see within the CENTER-TBI hospitals that 48% of patients who receive a CT brain scan for traumatic brain injury are in the emergency room stratum and only 17% in the ICU. Whereas within the core study, we've had some difficulty persuading patients in the emergency room stratum to take part in the core study. So hence, our core CENTER-TBI data is more dominated by the ICU patients who are a captive audience. When we look at the median age in the registry, you can see that in the ER and the ICU stratum, the median age of patients is 51 years, with an interquartile range of between around 30 and 70 years. Patients admitted to hospital with TBI but not to critical care are significantly older in the registry. They're 64 years old on average, with an interquartile range between 40 and 80. If we look at the core data, the admission stratum is also the oldest stratum within the core at 53 years. If we look at internal validation, it's very good between the core and the registry for the ER and ICU stratum in terms of having similar age. But the core versus registry for the admission stratum shows us a discrepancy of around 13 years. So you can see in this slide that on average, within the registry, admission stratum patients are 13 years older than in the core. And there's a reason for that, and it's the exclusion of patients with cognitive impairment from the core, which are a large group of TBI patients that generally present with falls. If we look at male gender and the gender distribution across the strata within the registry, you can see that males predominate throughout the strata. And we can see that percentage of male preponderance is a marker for the severity of TBI. So male preponderance is 56.3% in the emergency room, 59.8% within the admission, and 72% of TBI patients on ICU are male. If we look at the core, the male preponderance is also highest in the ICU and has a very similar percentage to the registry, and that's also true of the emergency room. But within the admission stratum, the male preponderance in the registry is 5% less than in the core. So this slide shows you the overall male preponderance in the different stratum with the core and the registry. Moving on to mechanism of injury, on your right-hand side you have a mechanism of injury breakdown for the stratum within the registry, and on the left-hand side for the core. Low falls are in red, road traffic collisions in blue, high falls in light green, and the purple are assault patients. And you can see there's some differences between the core and the registry. So in general, low-level falls predominate in the registry, ER and admission stratum. Road traffic collisions are the most common mechanism of injury in the ICU stratum. High falls are more common in the ICU stratum, and assaults have the highest preponderance within the emergency room stratum. And there are some discrepancies in terms of the internal validation. It's excellent within the ICU stratum in terms of how the mechanisms of injury rank is set up between the core and the registry. Within the admission stratum, because there are more elderly fallers in the registry, low falls predominate, whereas road traffic collisions are more common in the core admission stratum. And within the ER stratum, assaults are more common in the registry than in the core. What about the clinical characteristics that patients present with? Here's the presenting Glasgow COMA scale in the core and the registry across the three stratum. And you can see generally patients with traumatic brain injury receiving a CT and being discharged from hospital or admitted to a ward but not to critical care generally present with full or mildly impaired consciousness, whereas patients who have been admitted to intensive care have a lower level of consciousness, a median GCS of 12. And the core is highly representative of the registry in this regard. Looking at the injury severity score, so this is the overall anatomical severity of injury, not just of the traumatic brain injury, but all the injuries that the patient has sustained. And you can see excellent internal validation here. So a median injury severity score of 4 in the emergency room stratum in both the core and the registry, of 10 in the admission stratum in both the core and the registry, and in the ICU stratum in the registry, the median ISS is 25 and 29 within the core. So generally, in terms of internal validation, we have excellent validation of the core within the registry for overall severity of injury, and the injury severity scores are what you would expect from other studies. Looking at some of the other factors that affect prognosis after traumatic brain injury, particularly the median systolic blood pressure on arrival at the emergency department, and there's really a remarkable degree of normotension in the patients in both the core and the registry. Within each stratum, within the core and the registry, the median systolic blood pressure at presentation is usually very close to 135 millimeters of mercury, with a fairly narrow interquartile range between 113 and 150 millimeters of mercury. And again, this high degree of internal validation is shown on this slide. In general, patients are normoxic when they present to the emergency department. The percentage oxygen saturation is nearly always 98 or 99% in both the core and in the registry. Looking at survival to discharge within the registry, you might think that within the ER stratum it should be 100%. It isn't quite 100%. It's 99.2%, as we do have some deaths in the emergency room. The mortality is just under 3% in the admission stratum in the registry and is 19% within the ICU stratum within the registry. And we're still waiting to work out this data within the core. So in summary, what can we say about TBI epidemiology from the CENTER-TBI Registry to date? We can say that on average, patients with traumatic brain injury have a median age of 50, but are older in the patients that fall and are admitted to hospital. There's male preponderance throughout the TBI presentations to our hospitals, but particularly so in severely injured patients who are admitted to intensive care. Generally, low falls are the predominant mechanism of injury, followed by road traffic collisions, but these and high falls predominate in the ICU stratum. And generally, we've got good validation in the core versus the registry. In terms of the clinical variables, majority of our patients are presenting with a full or mildly impaired level of consciousness, even in the ICU stratum. The overall injury severity score is mild, moderate, and severe across the three stratum, as you would expect. And generally, patients are normoxic and normotensive when they present to us. The survival to date, as I've highlighted, is quite good, 97% in the admission stratum and 81% in the ICU stratum. So in general, in terms of the internal validation of the core versus the registry, we have good internal validation for the clinical demographic variables and excellent validation of the clinical variables. We've got higher recruitment of older fallers to the registry, which are in line with the inclusion criteria of excluding patients with cognitive impairment to the core. Comparing the core to the registry as a whole is not meaningful because there's such big differences between the stratum, and we have preferential recruitment to ICU within the core and preferential recruitment to the ER within the registry. So the next steps for the registry work package are to look at the validation by country. We're going to avoid statistical tests to compare medians and interquartile ranges and proportions in categories to avoid excess use of statistics. We're going to look at more variables such as the findings on CT scans, the timing of CT, emergency interventions, and the discharge destination. And the external validation with trauma registries across Europe is ongoing. So that was all I had to say, and thank you for your attention. Thank you.